Okay, so case one, a 54-year-old man referred for venous duplex. He has bilateral lower extremity swelling, visible varicosities, and his waveform is as shown. So the question is, what's the most likely etiology for his edema? And if we can start the audience response. Okay, fill in your answers here. All right, answer 3, and that's correct. So about 2/3 of you got the correct answer here. So the answer is pulmonary hypertension. So again, what you're seeing is that above and below baseline flow in the vein, pulsatile in nature, consistent with right side cardiac pressure or volume overload. All right, so good sensitivity, specificity of this. I don't know that I used to report this out, but probably in the last 3 to 5 years, I've become much more aggressive at reporting this out because I think it gives the referring physician a lot of information, particularly if this is coming from the surgery services. They may not really have thought about what's going on with the patient above and beyond some lower extremity swelling. Okay, so next case, a 32-year-old gentleman with right upper extremity swelling after a weekend of raking leaves. And the question is, what is identified by the arrow? So does everybody see that picture? And we'll go next and start the audience response. So is the arrow showing us a brachial vein DVT, a basilic vein thrombus, which would be a superficial thrombus, a nerve bundle, or duplicate brachial artery? Okay, so 30% of you got this correct. So let's go, we'll see here. This is actually a nerve bundle. So you can see in the top picture here, here's your artery and your 2 veins. And not uncommonly, when you're looking at the level of the anticube, you're going to see that median nerve. And you can tell that if you look on your compression images. You'll see your veins going out and your nerve bundle staying there. If there's any concern or any confusion about that, go long on that. You'll see that it has striations, but it is a nerve bundle. And I would say that not infrequently we see probably several patients a year that this is overcalled and end up getting treated for a thrombus. Case number 3, a 54-year-old man who develops pulmonary embolism following his total knee replacement. This is what we found on duplex ultrasound. So what is identified on these images? Is this a popliteal artery pseudoaneurysm, popliteal vein thrombus, a Baker's cyst, or a popliteal vein aneurysm? Oh, good. So about half of you got this correct. All right. So this is a popliteal vein aneurysm. You don't see these terribly commonly. The incidence is truly unknown, but it's a minority of patients. It does have a high risk of deep vein thrombosis and pulmonary embolism associated with it, and recurrent thrombosis is common if it's not otherwise treated. This was a fairly interesting case because after this gentleman had his DVT and PE on repeat scanning, when we were getting ready to send him to surgeon to have this fixed, it was gone. So it completely involuted, which I had never actually seen before. And I scanned him myself because I wasn't quite sure that we'd ever seen something like that. It was kind of an interesting case. All right, case number 4. This is an 80-year-old gentleman with a history of colon cancer. He currently has no evidence of disease on his imaging. He was treated with surgery as well as chemo. He has persistent left upper extremity swelling. He had a left upper extremity port. And the question is going to be, what's going on in this image? So this image suggests what underlying etiology for his swelling. Is there more proximal disease? Is this a traumatic arteriovenous fistula related to his port? He has acute deep vein thrombosis, or is this appear normal? Okay, so this, if we can go back to the picture, actually the answer is A. So this is going retrograde. Okay, it's going negative away from the head, which is not what you expect in the subclavian vein. And when you see his additional images here, so this is a retrograde in the subclavian. He had a tremendous amount of collaterals just proximal to this, this finding. The vein was occluded proximally, and he was essentially having retrograde flow into his axillary subclavian vein. All right. Next case, 78-year-old lady with recurrent great saphenous vein thrombosis. Her duplex is shown here. She underwent endovenous laser ablation. Follow-up imaging done as Dr. Joseph described demonstrates these findings. Okay. So the question is, what is shown in the images provided? Is this E-hit? Does this represent an arteriovenous fistula, chronic common femoral changes consistent with prior DVT, or is this perforation and hematoma? Good. All right. So most of you got this. This is indeed E-hit. So this is the endovenous heat-induced thrombosis that we will occasionally see after either radiofrequency or laser ablation. And Dr. Joseph described you the findings. This would be a class 2, where there's non-occlusive venous thrombus that extended into the deep system, but a cross-sectional area less than 50%. Very good. All right, a 60-year-old lady with breast cancer, or she's a breast cancer survivor, has right upper extremity swelling. Duplex ultrasound demonstrates these findings. What is suggested by the images shown? So is this an arteriovenous fistula? Retrograde IJ flow. The top image is your jugular vein. Hyperdynamic IJ pulsatility, or there is a proximal obstruction. Okay, so split between 1 and 3. And actually, I think you both could be correct on this. So clearly this demonstrates there is an arteriovenous fistula. You have this very high continuous flow. Your velocities over here well over 100 centimeters per second, which you would not expect to see in the jugular vein. You've got a lot of turbulence in this vein. This is going retrograde. So again, in the this is the right subclavian vein. Head should be here, and this is retrograde in nature. So that's actually, there's probably both of those. What is demonstrated in these images? So are these images showing us typical valve cusp thrombosis, a frozen valve, a foreign body in the subclavian vein, or subclavian vein PICC line with thrombosis? Okay, so about a third of you got this correct. So this is actually a valve cusp thrombosis. So you can see the valve here, and you see flow, and here's that valve cusp with thrombus in it. You can see the vein is non-compressible. You know, we always talk about deep vein thrombosis beginning on the valve cusp. It's rare that we see it quite this early, but this was a case where we did see the valve cusp thrombosis very early in this patient, and that was the only thrombus that they had, was just isolated to that valve cusp. Okay. All right, a 28-year-old lady presents with right lower extremity swelling following a flight home from Jamaica. A venous ultrasound is performed for right lower extremity pain and swelling. What is demonstrated by the arrow? And this arrow should be pointing right here. Okay, is this valve reflux or valve incompetency, venous pulsatility, respiratory augmentation, or valve closure? Okay, so about half of you got this correct. So this is valve closure, and on your baseline here, this is 3.6 seconds. So your 1 second mark is this whole duration. So when you get that short segment of venous backflow, you will have, or you should have in many cases, a little bit of retrograde flow, just enough time for the valves to close and then demonstrate competency after a normal augmentation or even with Valsalva, as in this case. 65-year-old man presents with prolonged swelling after hip arthroplasty. The duplex findings are as shown. I'll give you a minute to look at that. What is demonstrated by the images? Acute right lower extremity deep vein thrombosis. Is this a popliteal fossa cyst? Chronic changes in the right popliteal vein, or a subacute vein dissection? Good. So about half of you got that. So you can see there's this fibrinous stranding in the lumen of the vessel, some echogenic changes with compression. The first slide I showed you, here's popliteal artery, popliteal vein. It's small but partially compressible, and this represents chronic changes in the right popliteal vein. All right, case 10, 36-year-old lady. She's past medical history is significant for an advanced stage cervical cancer. She's had regional lymph node metastasis. She's had a long history of chemoradiation, total pelvic exoneration, including a diverting end colostomy and ileoconduit. She's had multiple small bowel obstructions and a very complicated course. She now comes in dehydrated and malnourished, and while she's admitted, develops significant right lower extremity swelling and very severe pain in her right thigh. These are her duplex findings. So to clarify, just so you can see, this is the groin shot with the near Mickey Mouse. Her common femoral vein waveforms on the right and on the left, in case you can't see this, and these are her compression images. Okay, everybody okay on that? All right, so what is the etiology of her right lower extremity swelling? Is it a right common femoral vein DVT, an arterial venous fistula, pulmonary hypertension, or pelvic vein obstruction? So good, split 50-50. So she clearly has a right lower extremity DVT. We can see that, but you can also see by the waveform that she's also not getting adequate venous outflow. So this is pelvic vein obstruction. You can see this is our venogram. So she's got thrombus in her femoral vein and her common femoral vein, but when you look up in her pelvis, she's got clips, she's got a very small atretic iliac vein, and we, in the interest of palliation, took her and did some pharmacomechanical thrombectomy here. We stented the obstructed portion, and you can see after we did our work, we've returned normal venous outflow. Her leg was better. This was palliative in nature for her, but she was quite appreciative. Okay, those are all the cases that you have in your book. I have a few more minutes, and I have 3 additional cases. Do I still have a few minutes? Yes? Okay. All right. So this is a 55-year-old man who presents with unilateral lower extremity swelling, skin changes as noted. He had an ulcer here that healed with conservative care being compression. And you can see he's still got some edema. You can see the compression marks. The venous duplex results are as noted, and the question is, what are we seeing in this clip? And I'll let this play for a little bit. Give it one more cycle here. All right. Is this an incompetent perforator? A competent perforator? Duplicate calf veins? Or arterial occlusion? Can you guys play that again? Keep that looping for me, possibly. All right, so this is actually a competent perforator. And if I can go back, I'm going to go back to the slide that did run. So you can see with calf compression, we've got flow back towards our calf veins. So blue is negative. We're flowing back towards the calf veins here. There's no reflux. So despite having fairly aggressive skin changes and findings at his ankle, this is not necessarily the culprit. This is a competent, very large, but competent perforator. So no good trying to take care of a competent perforator. Okay, hold on a second here. There we go. All right, next question. What is demonstrated by this image? I'll give you a few minutes to look at this before we put on the audience response. Is this saphenous vein reflux? Is this acute great saphenous vein thrombosis, superior epigastric reflux, or an arteriovenous fistula? And now we can do the audience response. Interesting. Okay. So it might not be clear, but this is superior epigastric vein right here. This is your great saphenous. It's thrombosed. This is where knowing the history becomes very important in your patients. So this patient had a prior endovenous laser ablation. So you can see the great saphenous vein is thrombosed. It's competent, but we've got a marked amount of reflux up into the superior epigastric vein. And you remember coming in at the groin, we have multiple branches. It's not uncommon for us to have reflux back into, particularly the superior epigastric vein, less commonly because we usually get back past this, but the pudendal. So what is identified by the arrow? And there should be another arrow sitting right here. All right. Is this a femoral vein pseudoaneurysm? Is this inguinal lymphadenopathy, a femoral artery thrombosis, or a profunda vein DVT? Okay. Good. Good. That's outstanding. So 2/3 of you recognize this. This is isolated thrombus in the profunda. Here's your femoral artery and femoral vein right here, and you can see that, we'll show it here, with compression, the femoral vein is obliterated. The profunda vein, however, is not, and on the color, you can see there's no color fill in the profunda, and this is a profunda vein DVT.